Welcome. Hi, I'm Mikki, and this is Mikkipedia, where I sit down and chat to doctors, professors, athletes, practitioners, and experts in their fields related to health, nutrition, fitness, and well-being. And I'm delighted that you're here. Well then, everyone, I hope you're having a fabulous week. So, bit of an update from me. Those of you who follow me on social media will see that last week I was out a little bit with some Achilles tendinosis. I am happy to report that after a bit of massage and stretching and crossing my fingers, the Achilles is now behaving itself, and we did an awesome run in the weekend at Hanua's run hike really. And more importantly though, which I was super stoked about in addition to my Achilles, is just that my whole mental game is on for these next events that I've got coming up. So usually at about this time I start talking myself out of them, but I did not throw my toys at all during that 5 hours, which was amazing, and really enjoyed it, and then backed it up with an easy run in Riverhead the next day. In addition to the body responding well to the training, and I took the entire week off running, I also wasn't overly worried about that, because if you listen to me on Fitter Radio with Bev, he talks a lot about the kind of utilizing cross training if you can't do your primary activity, and just the science behind why that's useful. I didn't go crazy though, or do any ridiculous length amount of time on any sort of cardio equipment, just because we'd had a couple of weeks of decent running, which was probably why my Achilles was playing up anyway. So pretty stoked with that. And the other update is we have now got live on my subscriber site recipe only access to over 600 different recipes, my weekly emails. You get access to pick my brain on any of your nutritional queries. It's a monthly payment of just 12 New Zealand dollars a month, so it's not overly expensive, and it's a great way to get some meal inspiration. 99% of the recipes also have macronutrient counts for people who are interested in tracking their macros, and also for people who want to support the podcast. I guess this is a little bit like Patreon, where for $12 a month you get all of the benefits that I just described. Of course, if you do want a meal plan, I have my monthly meal plans that include all of what I've just described, plus a 28-day meal plan for real food nutrition or athlete meal plan. I also have my fat loss plans available, Flow and the Man plan. I have the keto longevity plan for an isolated, science-backed 5-day keto longevity approach. And spring edition of Monday's Matter is about to be released also. So there's a bunch going on my website. I just thought that I'd mention it at the top of the podcast so you're in the know. And this week on the podcast, we have the second part of my interview with Dr Andrew Koutnik. Now, for those of you who obviously listened last week, you'll know about Andrew. He has type 1 diabetes. He was diagnosed as an adult. And in addition to his own studies on nutrition, exercise, and metabolism, he's done a huge amount of research looking at low carbohydrate diets and their efficacy for type 1 diabetes. And in addition to that, he's got his TED Talk on the subject. He's also written a bunch of papers on the topic, and we just carry on our conversation from last week in this week's podcast. So if you missed last week's podcast, I encourage you to push pause, go back 1 week and take a listen to part 1. And just FYI, Andrew can be reached at andrewkoutnik.com. That's AndrewKoutnik.com. And he's got a whole heap of research in and around type 1 diabetes and low carbohydrate approach there on his personal website. And you can also find information for him at the Florida Institute for Human and Machine Cognition, where he works as a research scientist. So without delay, here's the part 2 of my conversation with Dr Andrew Koutnik.
Hey Andrew, I know you've done this approach for like low carb and type 1 diabetes for like 10 years. You know anyone else who does? And I was like, no, I've literally like never met a single person my entire life who's done this. Actually, I'd say that back. The one person who first I talked to about it when I was first going there. So essentially one person, but in essence, no one else. And she's like, well, there was this person presenting this conference, and they like are part of this whole community who does this. I want me to connect you with them. I was like, yeah, absolutely, that'd be great. I've never known this to be a thing, and that happened to be type 1 grit. So I find out about the group, get introduced to them, and I join the group. And in the first 24 hours, as I'm looking through the group, I'm realizing, holy smokes, man, these kids in this group, like the kids in this group, were achieving glycemic control I had never seen in my own life.
Yeah.
Like unbelievable levels of control. Adults, kids, people from all walks of life, living in all parts of the country, were showing, HbA1c values, less than 5.7.
Yeah.
And a lot were less than 5. Just incredible numbers.
Yeah.
At that point in my life, I had never been above 6, except for when I was initially diagnosed. So I'd always had pretty good management. And I had a 5.6 before, et cetera. And I felt pretty good about that. When I started, I was like, man, like they're achieving some unbelievable, numbers here. This is incredible. It's super motivating. That really, I had gotten introduced to that group. And when I saw that, it honestly quite literally changed my life, because it made me immediately realize, whoa, there's a lot of times that I thought, it'd be great to speak about this journey that I went through as a type 1 diabetic. But the truth was, I was always very hesitant to do that, because it's one thing to say, yeah, it worked for me.
Yeah.
But to say it worked for me, so it's going to work for you, is dangerous. Really, it really is. But then I'm seeing hundreds of people. Like a post goes up, 24 hours later, there's 100 people showing their numbers. Like,
Yeah.
maybe someone's faking that, but all of them, no way. And my own personal journey made me realize, like, it's totally possible. And it just built around this awareness that, wow, like this is really an opportunity for a lot of people to implement a strategy that literally was achieving results that no other therapy right now gives a patient with my diagnosis that opportunity to get normal glycemia through managing.
It's amazing, Andrew. I know I think I came across type 1 grit maybe about 5 or 6 years ago or something like that. Just like your colleague Angela, I went to a conference and heard about the group. And as a clinician, like I know that it's a close community, but as a clinician who is an advocate for lower carb, just wanted to learn a bit more. I'm pretty sure they let me in the group, and it was amazing to see how committed these kids were. Because like you say, like particularly children, if I think about how people manage their health conditions and what drives and motivates them, sometimes it's easier to be driven and motivated when you've got the very real consequences of not right there and you can see them, but kids don't see that.
Yeah, typically not, right? And the thing I've grown to appreciate, and a lot of that's, let's say you get your kid and you walk into the hospital. I was 16 going on 17, so I was at a point where when this came on board, I had support from my parents. Obviously, I was very lucky to have that. Some people don't, but for the most part, it very quickly became my own journey.
Yeah.
Almost like right off the bat. And when you're, very young and a kid, it just falls on your parents' shoulders. And I know a lot of parents who were managing their children through other approaches and just felt overwhelmed. It's usually what ends up happening is because this is not a part of the traditional approach, not even close. So, for someone to find this, usually it's because they're like, I'm so overwhelmed. There's got to be something. Like, is there nothing else? Like going up to this number, coming down to this number on a regular basis, just seeing their emotions fluctuate and change, and they have less control over that. So the parents feel the full brunt of that. And of course, they put a lot of weight on their own shoulders as parents. I'm a parent now of a 22-month-old, and I fully understand that. If my son got diagnosed with type 1 diabetes, which he has a way higher risk because I do compared to the general population, I feel much more empowered. But a lot of parents, it's on you. Like, know that they're not all the way there and capable of doing this. You have to kind of guide them through that until they get older and more established and on their own. And, so a lot of this comes on to, is the parent willing to go on this journey?
Yeah.
Because, there's the one fear, often the one fear parents when they go on this is, well, I can't eat the food that all of my friends are eating, or I can't do this, or I can't do that. And really, truly, that might have been a real legitimate concern at one point. But if you do some objective analysis, we actually did this when we were going about writing a review that went in JCI for the 100th year anniversary of insulin discovery with David Ludwig, Belinda Leonards, and Joseph Wolfster, and other colleagues. putting that together, and it was an honor to be a part of that. But as a part of that, I never got a part of that publication, was looking at the actual populatory involved in the diet using objective metrics. And I'll just make it succinct and say it is one of the most popular diets in the world. And because of that, the options around it for patients to manage and find, alternative strategies are readily available to you. So you might not go to the grocery store and find, and actually you can now. Like nowadays, you can actually go to the store and find foods that fit in that category because the industry has realized the demand and started to meet it. But you can make, like ketchup, pure sugar, barbecue sauce, usually pure sugar. You can recreate these really well. Now, like I say, like all low carb options are like as good. Some are actually better. Some are definitely not as good, and some are right at the same. And one of the examples, like we at our house make a lot of ketchups and barbecue sauces, and when we actually started to make it ourselves, we could make it identical to what was on the market. And we would just replace sugar for something like stevia or allulose. And it would taste exactly the same if you did it right. Not every time. We weren't hitting a home run every time, but it was all like exactly the same. I'm like, whoa, like that is a ton of calories for nothing.
Yeah.
And it tastes exactly the same. Like, honestly, this should just be supplemented out. This would help everyone in general. Why do we even need that? It could help a lot of people. So those type of options are readily available to people on a regular basis to tap into. And there's so many recipe books. So, Caroline Ketchum is a big advocate for the type 1 diabetes community. We use a lot of her recipes. And there's dietdoctor.com. There's so much out there for recipes and options for people trying to navigate this journey. So maybe it isn't walking to the grocery store and getting all your foods. Like nowadays, you go to the food, if you want to eat a high carb diet, you go to any grocery store and you can fit that demand. If you want to eat a low carb diet, you can do that. You just be a little more educated and then, reinvent foods. And you really aren't giving up anything really from that side of things. So, it is an adjustment. It is a journey, especially from a parent, helping a child on that journey, because it usually requires a parent to kind of ingratiate themselves in this approach too. It'd be weird if the child's like, well, you're not doing it and I am, so a lot of parents have to own this themselves, which I really admire. I've seen some incredible parents doing that, and, they would do anything to help their kids improve their outcomes. And so seeing that was absolutely incredible, and seeing the kids, the adults, everything. At this point, it wasn't like, 50, maybe 60 people. It was like hundreds of people showing these results. And I was just like, man, if this is happening for these people, just everyone else doesn't know about this. Maybe they should. And then this is when the opportunity came about at USF to potentially do a TEDx talk. Bid in for it. I was picked as one of the people, and I also, because of the novelty of this, so we have to appreciate that when you see a type 1 diabetic with, like, for example, my CGM, right? So if you see a type 1 diabetic with numbers or just like values that, like if you look at CGM value and you're trying to get an idea, okay, is this, they have normal blood sugars or not, et cetera. So, for example, I don't know, it's like 107, pretty solid flat line, that's pretty normal day. It's not always perfect. Okay. It's not, but that's normal for me. And that is 100% abnormal for most people. And I know what that feels like on a regular basis. So when someone taps into that and gets an opportunity, a lot of times I actually talked to a lot of physicians when they first saw what ended up being the paper that came out of studying that group, because of the novelty of what was being shown in so many patients. A lot of them were like, how do we even confirm they have type 1 diabetes? Because that's a legitimate concern. People might not believe it. And so it was fascinating because, that really illustrated the whole point. When you get diagnosed with a disease, you hope you can take medications that will resolve that disease, to give you the power to at least control it. And insulin certainly was the biggest discovery of all time that led to that. But advances since then have helped refine that: CGMs, pumps, other insulin types, etc. But nothing's quite given normal glycemia as an option readily to people on a consistent basis. And at this point, Harvard and Duke and other colleagues got together and actually studied that unique group, doing doctor-confirmed data. And I might have already mentioned this before. I apologize if I'm reiterating this, but those, when they so they actually so the patients enrolled who were from type 1 GRIT for the study, and the doctors actually called their doctors to confirm their results. So it wasn't like, oh, I can just report whatever I want. Like, the doctors actually confirmed their lab results and illustrated, okay, in this unique cohort following this strategy, this is the outcomes we're seeing. And their average, with like, I think 42 or 48% pediatric patients, so half are children, was a 5.67 HbA1c. realized that prediabetes starts at 5.7, meaning
Yeah.
the mean of this cohort was not even pre-diabetic in their values. Their average blood glucose was around 100. The standard deviation was 28 milligrams per deciliter. These are unprecedented numbers for a type 1 diabetic, essentially showing that normal glycemia was an option.
Yeah.
It was 316. I think 300 actually reported their official results for this HbA1c. In essence, it showed that at least these people were able to do it, and that opened the door, because for me, seeing that, I can say, okay, it works for me. It may work for you. It made me very tentative, and I was honestly definitely afraid to get out and publicly say you should be doing something that I personally did, because I know how dangerous that gets in all walks of the research in life. Scientifically speaking, people may it doesn't always translate like that. And seeing that cohort, I'm like, that is 300 people.
Yeah.
And I've done it myself. They're doing it. And that body of people who are doing this now are growing exponentially. And the physiology and biochemistry of how we know carbohydrates and insulin work in the body, it's just a clear story. Carbohydrates cause a well-defined postprandial hypoglycemic response if you don't have insulin present. Insulin drops it down. The less carbohydrates you put in, the less insulin you put in, the less chance you're going to have for these fluctuations, period.
Yeah.
So it just makes sense.
Andrew, how has your low carbohydrate approach changed over the years? Has it changed at all? Like, you've said that you've experimented quite a bit. Like, when you delved into the low carb approach, has that modified to where you are now?
Absolutely. So I've gone through multiple iterations of this. So the one thing when I went on low carb, my ultimate goal was never necessarily to have elevations per se in ketone bodies or to be in ketosis. My goal was just to have normal blood sugars. Like, that's all I cared about, because that had the biggest impact on my everyday life and acute quality of life. So that's how I managed it. So originally when I first did this, the first go around I did this, I was much higher in protein. And man, I was pushing like over 200 for sure grams, split across multiple meals. And then I'd have, this really small quantity of either broccoli, asparagus, or like spinach.
Yeah.
And then I'd have fat kind of around the same grams of protein. At that point I was around 250 pounds. So there's some literature saying that 1 gram of protein for 1 pound of body weight is maybe optimal for muscle synthesis for athletic endeavors. So I was shooting for that. The grams of protein were about the same, and I just kept carbs into the range where I was not having blood sugar glycemic problems ascribed to them. So I basically lowered my carbohydrates to optimal glycemic control, which ended up being pretty low because that just ended up working for me. But over time, my life has become very different. My priorities aren't going into the gym and trying to be as big as strong as I can possibly be. It's trying to be a good dad, to be efficient at work, have my cognition at the best place possible, and eating all the time nonstop is certainly doesn't help me for a lot of those things, having to rely on meals at certain times. So actually now my life is much different, as a researcher and as a father, and, making sure my priorities are aligned in an appropriate way. I often wake up nowadays and I have some coffee, maybe put some MCTs in it, and I'll just go until I'm about 2 hours before I'm going to work out, which I have a home gym. So that has helped a lot. It's pre-COVID too. So it helped a lot just with efficiency and time to be able to spend more time and be more efficient. And so I honestly sometimes just eat a meal before I work out, not because I actually want to. I'd rather just be able to go downstairs and immediately work out. It's because I can just tell a big difference in my ability to actually live. Because I like lifting weights, so I can actually build and get performance benefits and recovery benefits from that. So I'll eat I'll eat post, and then I'll always have usually my largest meal at the evening before bed. The reason I do that is because if I place that early in the day, I just feel sluggish. I don't feel good. I don't feel energetic. And so if I'm going to have something like that, that's going to be more robust in calories and more dense, I guess is the way to put it, I like to have that later in the day, because if I'm going to feel, let's say, a little more tired after having a bigger meal, I'd rather be right before I'm about to go to bed. Not before I'm about to work or do other things that require me to be alert and engaged. So over the time, I'll just say that my timing of meals has totally changed. The frequency of meals has gone down, and the consistency around it has also changed. So usually I have very patterned meals, 4 to 5 meals on the dot. And that was just great for starting out because it really set a routine that I could stick with. But I also, like nowadays, with everything that's going on, all the changes, travel, family, like all these things, it's like food is not my biggest priority. working out is no longer my biggest priority. I just want to get them in and do a good job. So honestly, it's all over the place, but having these meals with lower glycemic impact, it's easier to kind of deal with it being placed in random spots throughout my day, which I will say isn't optimal. I think macronutrient composition of the food is king in glycemic control and type 1 diabetes, but I will say consistency is a strong secondary king and the management of type 1 diabetes, because with all the factors that change, if you have consistency, you can be more predictive of what you would expect. And so while I can't necessarily rely on that consistency all the time, having foods that make it easier, that if I don't necessarily get it exactly right, that I'm not going to have this off the bounds deviation. It's much more manageable, and that helps tremendously just because nowadays it's not about physical performance as much as it's cognitive performance in my career and just overall life. So that's what I shoot.
Yeah, no, absolutely. And as I think we may have mentioned with Dr. Bernstein's approach, he's not keto, as I understand it, is he?
No, his approach is high protein. You have fat that comes along with it. You don't really track that. There's no pushing of fats, so to speak. I guess is the way they like to describe it. That's not being promoted. It's not like you go eat a bunch of butter and bacon or any of those type of things. It's just like you eat high quality, high protein, and you have fat that comes along with that. You just keep your carbohydrates low, and that's how you manage. And I am, this is an area of controversy for sure. But I would say that I think that is a strong strategy if you're absent of carbohydrate, the insulin response, that having higher protein for certain populations might be a benefit to maintain that. Maybe if you're not worried about growth or other factors, that might be a less concern, and you're trying to tap into more of the, ascribed benefits that might have come along with having, normal nutritional ketosis levels of ketone bodies, somewhere between 0.5 and 5.0, somewhere around there. If you want those, you want that potential benefits, then you have to you definitely have to lower carbohydrates, but you probably also have to be more restrictive on the protein of things. Depends on the person, but for each their own. There's different journeys, and different people go about it different ways. I know someone who's pure vegetarian, or actually maybe vegan. She's actually very publicly acknowledges this. Her name's Carrie Douglas, an incredible human being. Learned a lot from her, actually. I can call her a very good friend, and she has amazing things. But she does this diet purely. I think she's either vegetarian or vegan, which is amazing to see, because a lot of times people would just never associate. Okay, I want to restrict carbs. There's no way I could be a vegetarian or vegan. Well, no, she has. And I will tell you, I've actually learned a lot of recipes from her that I actually truly love and enjoy, which I would have never known of if I had not gotten to know her. So.
Yeah, nice, Andrew. And you touched upon growth when you talked about the benefit of having a high protein approach. And as I understand it, one of the major criticisms of a low carb approach for children, and if I'm just thinking about children because of the type 1 GRIP group, I suppose, is that growth will be impaired if they drop the carbohydrate out. And I believe that's one of the myths, if you like, or one of the notions that you discuss on your website. So are you able to talk through what those fears amongst practitioners might be with regards to the low carb approach?
Yeah, so this is actually a really important topic to me personally, because I had talked to a lot of people in this space, and for me, it was the most commonly brought up thing. So the most commonly brought up thing was, well, what about these concerns I've heard about this diet? And usually these revolve something in another disease state, or ascribed to a high fat diet, or something related to lower insulin levels. And I'll be truthful, a lot of those are totally make sense. The concerns are the main ones that typically come up are ketoacidosis, hypoglycemia risk. So ketoacidosis, because if you're already at risk for ketoacidosis, if you go lower insulin and lower carb, you're only going to increase that, so are you at more greater risk? Another common risk or concern is hypoglycemic risk. Well, if you have less carbs, won't you be at greater risk for going hypoglycemic? Another one is cardiovascular disease. Okay, well, if I'm having more fat, isn't that going to increase my cholesterol, LDL, and then perpetuate my risk for, long-term cardiovascular damage? There's also kidney dysfunction. A lot of people who go on this diet, as we just talked about protein composition, a lot of people who go on this diet, they may feel that, okay, well, I've heard that there might be a problem with protein in kidney health. I'm a type 1 diabetic, supposedly at higher risk for all microvascular diseases and nephropathy, the damage of the small vasculature within the kidney. Wouldn't that increase my risk too? And then compliance is a concern, quality of life is a concern. So the first one you talked on is pediatric growth. So it's important to actually understand, after having talked to a lot of clinics, some of which were world-class clinics and clinicians about this, I've realized that it was important for me to directly address this and actually like kind of systemically look at this in a very unbiased manner.
Yeah.
Because ultimately you have to weigh the benefits against the concerns. And so when we talk about, pediatric growth, that's a common one because, well, there's been some literature historically that in seizure patients, a small percentage of seizure patients who go on a low carbohydrate diet, they had, reported some growth impairment compared to the mean. There was also a small case report done out of, I think, Australia, where they specifically actually asked to the community, the clinical community they knew of, have you guys ever done or heard of any adverse event with low carb? Because we're trying to report what those are. So that also came out. So there was this concern about, will this cause some type of growth deficiency because, hypothetically, there might be a risk. When you actually look at type 1 diabetes and what is actually causing risk for pediatric growth, the number one risk factor is glycemic mismanagement. So you can actually look at risk association between glycemic mismanagement, like HbA1c and other markers, and actually impaired growth. So actually, the type 1 diabetes growth curve is slightly smaller than the general population, and it's been associated with glycemic mismanagement. So that's a risk.
Yeah.
Nutritional deficiency is another one. So when a pediatric patient actually goes on this diet, oftentimes, if you aren't well informed on how to do this, you may not formulate it well with nutritional dense meals, and you may inadvertently just be calorically restricting. And nothing is a more powerful growth impairment tool over anything than caloric restriction.
Yeah.
But here's the thing. When you actually look at the literature on type 1 diabetes and very low carbohydrate diet, the data right now, even though there is some bias and it is limited in its capacity to draw extreme assumptions or calculations, but what we know from the literature right now, and there have, I think, at this point been 18 separate cohorts, I think 15 or 16 different papers out on actually very low carbohydrate at this point. I might be getting that totally wrong, but I know there's around 16 to 18 actual cohorts of data in that group that one, the glycemic mismanagement obviously dramatically improves. You see actually in the very low carbohydrate cohorts who have done in type 1 diabetes, there's actually a large number of them that outside of that pediatric paper I talked about with the 5167 HbA1c, a lot of these reports actually indicate these patients are achieving non-diabetic HbA1cs. So it improves the glycemic control, which is a risk factor of growth impairment in pediatrics to begin with, in type 1 diabetes specifically. But nutritional deficiency is more about being educated on how to go this approach and choosing it wisely. When you actually look at the true outcomes associated with pediatric growth and type 1 diabetes, there's totally insufficient evidence to make any real claims about whether it does or doesn't. So at this point, it's totally hypothetical. In fact, to my understanding, the one analysis that actually looks at the patients who are doing this approach, there was no growth impairment compared to type 1 diabetes trajectory. So right now, it seems like there is, one, it's limited evidence, but two, the evidence actually is in support of not a nutritional growth deficiency, at least if you weigh according to the study's power, like to actually draw a conclusion.
Yeah, because it feels like, as you said, like that people look to the data on children with epilepsy who are following that classical ketogenic approach where it's matched 4-to-1 fat to carb and protein. And as I understand it, that's where some of these concerns come from, as you said, with children who have seizures, right? So it's almost like conflating that problem onto this particular group just because they're children.
Yes, and that is exactly what's happening, but it isn't completely unfair, right? If you have limited data, you have to look at the limited data that is there.
Absolutely.
And so that is what people have done. So that's why I say when people make this jump to say, well, hold on, won't it cause pediatric growth impairment? It's not off the range to say, well, hold on, there's just data in these other populations where that might be the case if we don't have it in this one.
Yeah.
But right now we do at least have some preliminary data in this one indicating that these, N of 6 case reports, but that study specifically actually asked only for those patients who had a problem.
Yeah.
So that report is only illustrating when someone actually fit that criteria. So by default, it fit that criteria. But when you look at the pediatric paper, those children didn't see growth impairment.
Yeah.
So And that's a much larger cohort of N value. And they were actually ascribed to this very specific regimen where you actually do see the glycemic management improvements, et cetera. And typically that group is more educated on how to get a nutritionally dense, low carbohydrate based diet. So obviously there's more questions to be answered there from a research perspective for sure. But the evidence right now does not support that that is actually founded based on the evidence at this point.
Yeah. And so that's growth. What about the hypoglycemia?
Yeah, so hypoglycemia is always one of the biggest concerns because it's really the acute concern, right? So when someone has type 1 diabetes, often they live in hypoglycemia because they have this large variation around the mean. And so if you keep lowering your mean with this large, variance, at some point your lower end of the variance is going to start creeping into hypoglycemia. And then if you get too low, it can be very fatal, right? So the concern around that is, well, if you're having less carbohydrates, which help elevate blood sugar, won't you increase your risk of going low blood sugar? Well, the truth is that most hypoglycemic events are a sequel to what was previously a hyperglycemic event.
Yeah.
So if you're hyperglycemic, you usually take a bolus of insulin to correct for it. And oftentimes that might be not often, but it can be an overcorrection. And that's when usually you see hypoglycemic moments. But if you actually look at the data at what is actually a risk factor in type 1 diabetes, the type 1 diabetes specifically for hypoglycemia, HbA1c, a high HbA1c is a risk factor for hypoglycemia. And glycemic mismanagement in general is another risk factor. We know that the literature right now in type 1 diabetes and a very low carbohydrate diet, that HbA1c comes down and sometimes is the non-diabetic range. And we also see a dramatic reduction in the reports where they reported it for reductions in blood glucose standard deviation, meaning the variance around the average is much lower, meaning you're protected from these wide swings that put you at risk for hypoglycemia. And there actually is some real data to indicate that, at least compared to the historical evidence in type 1 diabetes risk, that the hypoglycemic episodes happen at a much lower incidence in those doing this diet than the general type 1 diabetes population. So that's worth noting. There are some limitations around that because obviously if you're in a study and you're specifically doing a dietary strategy in the study, you might have improvements by default by being in the study. So there's a limitation there. But the difference is multifold. So the difference is multifold less chance of that occurring. But we do actually have some data on it. It's very limited, but we do have it. So the actual concern around it, again, doesn't seem to match what the evidence on type 1 diabetes and very low carbohydrate illustrates, or the risk factors associated with it.
Yeah, and it makes sense, right? Because if you reduce the variance, that's the major concern. So yeah, absolutely makes sense. Now, Andrew, what about ketoacidosis?
Yeah, so this concern just fundamentally comes from basic biology. So if in type 1 diabetes, being the absence of insulin does a very good job of blunting the hepatic ketogenesis. So insulin at high levels can cause hepatic ketone levels, or ketogenesis in general as a process for the production of ketones from free fatty acids to lower. So when you have a lot of insulin on board, you can blunt that process. This is also why when you go to a low carbohydrate or fasting diet, when insulin comes down a lot, you can actually start seeing ketone production increase meaningfully by serum blood markers. So in ketoacidosis, in type 1 diabetes, when you don't have insulin, you ultimately start increasing the amount of lipolysis from the fatty acids. That those free fatty acids then go to hepatic tissue, your liver, and the liver, in the absence of insulin blocking the ketogenic pathway, allows for ketone bodies to be produced. That's a very normal physiological mechanism. Well, ketoacidosis occurs in type 1 diabetes because of the overwhelming lack or absence of insulin on board. So usually when you see ketoacidosis in a patient, their blood sugar levels is typically over 250 milligrams per deciliter. That's because there's a complete absence of insulin to manage it. You also see ketone bodies typically above 5, although there is some reports that there's risk for it as low as 3 to 5. And the true risk factors, so it's a completely different physiological state of what is nutritional ketosis versus ketoacidosis. And it comes down to just the pure absence of insulin in type 1 diabetes. But again, if you look at the hard evidence, so what are the true ascribed risk factors for ketoacidosis in type 1 diabetes? Number one, above everything, and it comes back to this, is HbA1c. A high HbA1c actually increases your risk for ketoacidotic events. So higher HbA1c, higher incidence numbers for ketoacidosis. And again, this comes back to glycemic mismanagement. So HbA1c and glycemic mismanagement are your primary risk factors for ketoacidosis and type 1 diabetes. And as we've already talked about for hypoglycemia and pediatric growth, we know that when type 1 diabetes and a very low carbohydrate diet, that these both reliably improve, again, to really extreme levels, which again, lower those risk factors. And just like hypoglycemic episodes, we actually see a lower incidence of this DKA events in the type 1 diabetes community who do very low carbohydrate. Again, just like hypoglycemia, the data is much more limited, but it's limited data. It's what we got. Yeah. So based on that evidence, we see lower incidence of these severe adverse events, but it does make a lot of sense. If you have greater glycemic control, you would expect a lot of these things to improve when almost all of them are at risk because of glycemic mismanagement to begin with.
Yeah. Yeah, it's really interesting because that was, as a clinician who uses low carb, that's a lot of the pushback that you get from doctors of patients. Clients would come to see me and they have type 1 diabetes and they themselves want to follow a lower carb approach. And they're like, my doctor is totally against it because of diabetic ketoacidosis. And I'm going to, the other one, which I know that we can talk about, is the risk of cardiovascular disease. There's such a fear around this stuff.
And again, I have to give credit and be fair. It does make sense that there would be a fear. If you're, I heard a great quote recently. Often people, the philosophy of do no harm first, often comes at the expense of actually doing some good, and oftentimes doing some really good. Exponentially, you do exponential good, but if you're potentially going to do any harm, a lot of people will go for do no harm first before they even consider how much good could be done, even at risk for that potential harm. So I understand that, but that's okay because we actually have data to look at to compare these things. And so when it comes to cardiovascular disease, so we can actually, that's, in part why I made that website, so that people can actually go and look at the evidence revolving these things and make their own decisions, because these are tough decisions. And I think it's important to consider them in the big picture altogether. So for cardiovascular disease, there was a paper in 2016 published in, I think, in Diabetes Care, the NADA journal, looking at the hazard ratios that were accompanying the DCC and EDIC trial. And the DCC and EDIC trial, we've already talked about that earlier in this podcast, but that was the biggest trial ever done, 30 years, over 1,400 patients with type 1 diabetes. And they looked at risk ratios or hazard ratios for those, for various biomarkers revolving cardiovascular disease. And amazingly, but also not surprisingly, HbA1c came in first. So HbA1c was one of the most important risk factors for cardiovascular disease. But what was highly ironic is that the hazard ratios for total cholesterol, LDL, and HDL were essentially meaningless. So the hazard ratio for total cholesterol was like 1.008 to 1.018. So basically 1. Yeah. So the risk ratio associated with any change in total cholesterol was essentially 1, so nothing. And then LDL cholesterol was 1.008 to 1.072, I believe. Again, right at 1. And HDL was 0.976 to 0.995. So that was, again, all right at 1. So they seemed rather meaningless. But if you look at triglycerides has a ratio was like 1.554 range to somewhere around 2.923. And what's interesting about that is that carbohydrates typically drive up triglycerides and lower carbohydrates typically drop them. And there's all this concern about the idea that total cholesterol HDL or total cholesterol and LDL will go in an adverse direction because of the data around the general population that those two biomarkers are ascribed to cardiovascular risk. But in type 1 diabetes, according to at least this most recent analysis in the largest data set ever conducted in type 1 diabetes, looking at cardiovascular disease and the hazard ratio ascribed to them, those two biomarkers, total cholesterol and LDL, appear to be meaningless. And HbA1c appears to be king, as per usual, and then triglycerides seems to be much more important than either of those other two lipid values. But it's important to also realize when you actually look at the literature on these dietary strategies and what actually happens with them on type 1 diabetes and very low carbohydrate, as mentioned, HbA1c improves. Triglycerides often come down, but not in every report, actually. Insulin load also lowers. There's been some recent evidence growing, not in type 1 diabetes per se, but in other diseases, that insulin load can contribute to macrovascular disease, so which is cardiovascular disease. And that obviously typically lowers, sometimes to about a half or a third of the traditional normal value, I guess, based on normal means. let's say body weight, if that was a risk factor, that tends to go all over the place depending on what report you're looking at and what the intervention was. So hard to really make any conclusions there. Ironically, if you look at all the evidence in very low carbohydrate, total cholesterol when going on this intervention typically goes down. And that may go against all traditional logic on this approach, but actually the directional change, now it is elevated above 200, but the directional change from pre-intervention to post-intervention is actually lower.
Yeah.
And when you look at LDL cholesterol, it's again all over the map. It goes down, it goes up, it can stay the same. And then HDL, kind of like total cholesterol, it's very consistently goes up, improves. But the evidence associated with these in the context of type 1 diabetes and very low carbohydrate for actual outcomes in cardiovascular disease, we don't really have any evidence, right? So we have to look at these hazard ratios, these risk factors, and then how those risk factors actually change on the diet based on the evidence. And right now, they seem to, the ones that matter the most, HbA1c, triglycerides, and insulin load, those are some of the most reliably improved on this dietary approach, not even in type 1 diabetes, but actually across general population, type 2 and beyond. So
yeah, it's so interesting. And one of the other things that you mentioned was the effect of this type of diet on the kidneys.
So that theory came out, I think it was from Brownlee or Brownwell, I forget, I think it was Brownlee is the official name of the author, who put out a hypothesis paper back in the day that the concept that kidneys, the protein, the kidneys have to filter protein. If you increase the protein content in the diet or percentage or the amount of absolute intake of protein, that you'll further stress the kidneys. And that was a hypothesis paper. And ever since then, there's been a growing level of concern associated with it, and also supported by the idea that if you actually have kidney disease, that excess protein intake can exaggerate the disease. But there was recently a meta-analysis, and this is not in type 1 diabetes, but it's in the general population, where this theory originated from, actually demonstrating that higher protein intake does not drive kidney change or dysfunction at all. And that was kind of a hypothesis that never really maturated. Now, this obviously does change when you get into the context of actual kidney disease. But prior to the onset of kidney disease, there is insufficient evidence for it actually driving that, at least in the general population. But let's consider just specific to type 1 diabetes. So this idea that there might be a risk for kidney disease, well, again, back to what we've been talking about, the primary risk factor is HbA1c.
Yeah.
So if you can improve HbA1c, in theory, you would reduce the risk factor ascribed with kidney disease. And there's just insufficient evidence right now that protein intake drives, exaggerates, or reduces kidney dysfunction in the context of type 1 diabetes. So it's hard to make any assumptions there. And the reality is that you can change your protein intake ad libitum, so to your desire on this. You don't have to have high, low, or you can choose what you want. So you can, if you are concerned with that, you don't have to have high protein. It's a choice.
Yeah.
On top of that. And again, at the end of the day, we don't know how this diet in the context of type 1 diabetes with actual clinical outcomes meaningfully changed, insufficient evidence. So we have to look at these risk factors and the risk factor outcomes ascribed to the diet.
Yeah, no, that's awesome. Thank you, Andrew. And the last one, but you always hear actually with any kind of lower carb approach, type 1 diabetes or otherwise, is, well, no one can adhere to that. So what do you have to say about that?
Well, dietary compliance has been a concern in the general population for forever, right? So if you could get everyone to comply with a diet, you would have solved all of, if not most of the major problems across the world right now. And so that's just an inherent problem across our general population. Over 70% of America at this point is overweight. I think Europe, last numbers I saw were over 50%. So if you consider that, we know diet's a huge part of that. If you could correct the diet altogether and get people to actually meaningfully comply with interventions like this, then you probably could just fix all the problems, So there's been a lot of literature that when you put someone on an actual diet, that they have a hard time complying with it. And the true reality is that is not to any one diet. That is to all diets. So it isn't specific to this dietary strategy. It's just in general. And at this point, there's insufficient evidence. Well, so anytime you increase restriction in a diet, it might be more difficult to actually comply with it at the end of the day. But we actually don't have any evidence right now that indicates that people have a hard time complying with this diet in type 1 diabetes. It's one of those things that hasn't been studied, and we don't have the evidence for it right now. But I wouldn't be surprised if it's very similar to the general population, where there's always going to be people who have a hard time changing lifestyle, not specifically diet, not specifically eating any one diet, but just an intervention that requires some real effort up front to comply with. But here's something I will say, and why I think this is an interesting topic. A lot of times people think about this in type 1 diabetes and think, well, it's just going to be like the general population, they won't comply. But when you have type 1 diabetes and you eat a meal, you get pretty quick feedback on how that meal acutely affects your quality of life. You go hyperglycemic, you go hypoglycemic. There's that real rapid, quick biochemical feedback that tells you whether you got it right or you got it wrong. And so that gets to things like quality of life. When someone's on, let's say, a roller coaster ride throughout most of their life, up and down in blood sugars all the time, to extreme fluctuations that most people will never appreciate the level of impact that can have on quality of life. When you actually look at risk factors for quality of life, it's very multifactorial. But one of the primary risk factors ascribed to worsen quality of life in type 1 diabetes is HbA1c increasing and complications as well. And if you can lower HbA1c, there's in theory an ability to improve some of the primary problems associated with quality of life. And we also know that complications, the only data we have right now is on DKA, coma, hospitalizations, and those all seem to decrease based on the limited evidence we have with this approach. There's also been actual hard evidence to say that there is a subjective improvement in quality of life in these patients who are doing this diet. And that might fundamentally come down to the fact that they aren't experiencing these rapid fluctuations that we knew deteriorate quality of life, but they are also maybe more empowered because you're a disease where you oftentimes you can talk to a patient who might be struggling with this and they feel kind of like they're out of control sometimes with it. And this really puts some control in people's hands, at least based on what the evidence says right now and based on a lot of people I've seen and also my personal experience. So it just illustrates hope. A lot of the common concerns described to this diet, ketoacidosis, hypoglycemic risk, pediatric growth impairment, cardiovascular disease, kidney disease, compliance, quality of life, beyond. When you think of all those together, usually the concerns are the things that are first thought of, but we have to really appreciate that at the foundation of this disease, we have an absence of beta cell function and insulin production. And that means that we have to manually regulate our insulin control. And if we can improve our ability to manage that on a more meaningful basis, we are in essence doing our best to control the disease, or what is induced in us to the disease that induces a lack of glycemic control and through insulin lack of production. Either way, what I'm trying to say is that if we can do something about that, it empowers a patient. And if you can empower a patient, that's very meaningful. I mean, you hear stories all the time. You go on YouTube, you can find millions of stories about someone who did something meaningful in their life, and it totally changed their life and outcomes. And they want to tell everyone about it because they want to share those stories and as a fact. Well, if you have a disease that affects your everyday quality of life through the nutrition you're eating and the lifestyle you're having, if you can meaningfully change that by doing something as simple as low carbohydrate diet, and just changing your insulin, which typically lowers the price of them and the amount of insulin you have to even take, it's just something that I think illustrates a lot of hope. And I hope one day we'll have way more robust evidence around all these things, so there would be lack of hesitation to begin with. That's number one. But number two, that a patient will be able to walk in and know that there's an option on the table for them to achieve normal glycemia if they do X, Y, and Z. And, without that, you're using the tools that we currently have. And the hard truth is that those do not normalize HbA1c. There's no current tool right now in type 1 diabetes that has shown the level of ability to reduce HbA1c, the same level these low carbohydrate diets have in the literature. Nothing compares to it. I will also illustrate that the data is limited. It is very limited at this stage. We don't have randomized long-term RCTs to really pull from and say yes or no to this. And that's what most people want to see. They want to see these gold standard RCTs. That's typical clinical outcome expectations. We don't have that right now, but we do have some very interesting reports that illustrate that it's possible. And possible is something we need to consider right now because we don't have anything else that can do it. So that's where we sit right now in this community. And I'm hopeful that we'll learn more and figure out more. I mean, look, if I find out tomorrow this is not the best way to do it, then I want to be actionable on that. But for right now, based on what we know, the risk factors and the benefits that are described with this seems like for me personally, it's a choice I decided to make because one, it just subjectively improves my quality of life on a day in and a day out basis. But even beyond that, if you have hard objective biomarkers, they also seem to all move in the right direction. And the most important of them on a hierarchy-based system are the ones that are most effective, HbA1c and beyond. So.
Yeah, absolutely, Andrew. And I feel I was going to ask you, what do you think it would take for this to be, I suppose, adopted as one of the major approaches taken by physicians, but you've said it, it's that long-term data, it's that randomized clinical trial, which might not necessarily be, maybe it's kind of in the mix and it's occurring, but it's not there right now. That's what I love about your website, is that it is fully referenced with those peer-reviewed studies. It's a great resource that potentially someone could take to their doctor and say, look, could you just check this out? I'm really interested in this. And I want to try this approach, just to help their doctor as well, because it must be difficult as a physician to keep up to date with everything that you need to keep up to date with, I think.
Yeah, I mean, I think that was the first time, but one of the biggest discussions revolving low carbohydrate that really, took hold at the ADA conference was like 2 years ago. So the conversation is obviously happening. When the pediatric paper came out, I believe the New York Times article that accompanied it and talked about it was the most clicked and commented article for New York Times for 2018.
Amazing.
So obviously there's a ton of interest in this, and there's a lot of passion in this community. And I think that passion just fundamentally comes down to the lived experience. When you know what it feels like and you know what you can do about it, you get very, there's a lot of people who are very, very passionate about wanting to share that for those who may not be aware. And that can be very passion oriented. And I get it. Like, I totally get it. And there's been some extreme stories of people going to places and just being told you should never do that. I want to go down that road because that's not everyone, right? You don't want to paint one case or two cases as the picture. That's certainly not the case here.
No.
I think if there was, so here you asked a question though, like what would it take for this to actually be adopted? I think we're in a state now where I think there's a growing level of appreciation because of all the data on type 2 at this point. And now the growing evidence in type 1, because in the absence of anything else, that this is something we shouldn't just whisk away and say we shouldn't do that for all these ascribed hypothetical risks. At this point, I think there's a growing level of appreciation for, if it works for you, but what would it cause it for someone to go into an actual clinic and every single person to be able to walk out of that and probably be aware of it? Well, just like a drug. So if a drug wants to make it into a doctor's office to be prescribable to their patients, most doctors know all about drugs, right? So, and they usually know all the array of things that can be offered to a patient. If you want to match that, you got to do a long-term RCT. Do you actually need that for someone to do this approach and have meaningful outcomes? No, not at all. And many people make a strong argument that's literally that's being used as a unfortunate goalpost before people will actually consider it. And right now, the problem is that I live with type 1 diabetes right now, the second I get off this podcast, and for the rest of my life.
Yeah.
The likelihood that insulin is going to match carbohydrates probably isn't happening anytime soon. And if it did, it would be very dangerous because it'd be so rapid that it would probably induce much more severe adverse events.
Yeah.
The likelihood that the technologies being utilized to cure type 1 diabetes is just something that I have observed over the last 15 years, and also talked to some of the best beta cell biologists in the world, and they are not encouraging.
Yeah.
Many have said, I'm not getting it in my decade, and I might not see it in my life.
Yeah.
And I hope they're all wrong, for the record. I hope they're all wrong. But because of all those facets, and this is the one intervention that the evidence right now ascribes that someone could just go do it right now with this disease and correct a lot of the common risk factors associated with this diet, not only for acute complications, but chronic complications. I think that this is something that deserves that level of investment and effort to get that type of intervention out there, to test it so that there is that question is no longer there.
Yeah.
At the end of the day, is it needed? No, I don't think it's at all needed. I've done it without it being there for the last 15 years. But will it always be an expectation and goalpost until we go through it? Will it always be there? Probably.
Yeah.
So that's something that let me put it this way. If anyone is interested in trying to overcome that problem, they can contact me personally, because I've been trying to address that problem for the last year and a half.
Yeah.
So I'm hopeful. I'll put it that way. Okay. But we will see, because I'm fully aware that is an expectation and something that I think could be addressed at a scalable level, such that, well, I'll leave it at that.
Okay, awesome, Andrew. And do you know what I love? Your passion is absolutely obvious for this and understandable. You've also, what I absolutely love is that you absolutely caveat everything with that science mind, with that researcher mind, with the mind that you are not just someone out there saying, this worked for me, this will work for everyone. And I think that's what makes, I suppose, your message probably so much more powerful, because people can, you wear a number of hats, I suppose, or at least two, when you're standing here talking to me about type 1 diabetes, because it's your lived experience. You know the research, you've been involved in writing publications, you've got a real interest in that, but also understand why that's important. And I think that's what makes your message so powerful.
Well, Maggie, I'm honored you say that. I truly appreciate that. I feel a little bit of a responsibility as someone who's kind of gone down the path of researching nutritional strategies for actual interventions, and having gone through this myself and being aware of what comes along with that on a daily basis to try and do something with that. But I've also gone through a lot of experiences just through the inherent PhD process where things that I fundamentally thought were absolute facts, 5, 10 years later, or when I became knowledgeable enough, I realized I was totally ignorant.
Yeah.
And I was completely wrong. Having your fundamental established beliefs be objectively wrong, and that has happened to me multiple times over the last 15 years, is something that, if you just accept the reality that that happens, then you have to appreciate that some of the stuff, I might be saying here today may not last throughout my generation, throughout the test of time. Maybe something I'm saying here might not hold up to the science we end up learning about. I'm just speaking about what we know at this point.
Yeah.
But maybe at some point it might not. So it deserves that level of caveat. And I've also seen the dangers of over speaking what the science says.
Yeah.
And I try to be very careful about that, not to fall into that camp, because it's something that frustrates me in other topics and other areas. So I want to be careful about that. So, if I overspoke at any point here, I definitely want to apologize. I hope not to. But I do fundamentally believe that it's worth stating. I don't think I'm speaking out of bounds when I say that the evidence right now fundamentally shows that there is no current therapy for type 1 diabetes that will allow you to get normal glycemia on average in the population. It's not there.
Yeah.
We know insulins don't match carbohydrate response reliably. We know a cure is probably not coming for a decade, if not my entire lifetime. We also know the evidence illustrates on a very low carbohydrate diet, with the limited evidence we currently have, that it is and might be the most powerful therapeutic tool if implemented the way the therapy has been shown to be implemented in the literature. With that all combined, and also considering the concerns, the real risk factors associated with the concerns, and the actual outcomes in those biomarkers in the very low carbohydrate diet and type 1 diabetes, I am very hopeful. I am very hopeful that this is something that might be able to help many, many patients. Hopefully there'll be something way better than this that comes along. But I'm trying to address something for the lived patient right now. I'm not expecting something to come along and magically fix everything for everyone. I know this is something that many people will live with for the rest of their life. And there needs to be something that allows them to achieve this normal glycemia if they so choose to. And for that, that's why I'm here speaking today, so that someone will at least be aware of something that will give them the opportunity to be able to achieve that. They do it, they hate it, they don't want it, by all means. If they don't even want to try it, by all means. But if they do, and they didn't know about it, to me, that's unacceptable. And so I'm hopeful that that won't be the case for many people going forward, and we'll have better evidence to go forward to support that as well.
Andrew, you definitely didn't overstate anything, and I just have to thank you so much for your time today, because you, and of course yesterday, because this was a bit of a part 2 for us. I really do feel like that even if you get like a few people who weren't aware now aware, then what a win that is. And I feel like that's just that increased awareness in this space is what we can hope for at this point in time, really.
Yeah, truly, I agree with you. And then I'm hopeful that the remaining pieces will, I'll put it this way, the remaining pieces to help push a lot of what I said is the gaps moving forward, they're being actively worked on. So we'll see if we can ever pull a lot of that off to help on a grander scale, but we'll see.
That would be amazing. Andrew, thank you so much. So now, where can people find you? Are you on social media, or are you kind of fly under the radar?
I try to do both, if that's possible. I try to do a lot more of the second than the first. I try to spend as little time as I can on there, although I understand there's extreme power and ability to reach people and have an impact. So I do have a Twitter. I do have a Facebook that I very infrequently get to. I maybe check Twitter less than 15 minutes a day max, like honestly. But I do have a website that I do put information out there whenever I can. But my more active engagement occurs through probably Twitter. If there's anything worth meaningfully put out in there or touching base with anyone, that's one avenue to do so. And then the website is another way where I try to put out information that's just helpful for people for free. So if they're looking in or interested in that, just andrewkoutnik.com. I wasn't creative enough to come up with anything else. So that's where it is, just my name.com. I figured that was easy. So, yeah.
It was certainly easy for me to find to reach out to you. So, Andrew, thank you so much for your time and enjoy the rest of your day.
Thank you. You too.
Alrighty team, hope you enjoyed that as much as I enjoyed chatting to Andrew. He's like super approachable, so if you have any questions, I know that he's more than happy for you to reach out to him. Next week on the podcast, I sit down with my mate, Dr. Karen Zinn. Those of you who are interested in low carbohydrate will know Karen very well. She is the co-author of the book series, What the Fat. She's an advocate for low carbohydrate diets for health, performance, and weight loss. And she is a senior lecturer at AUT University. And Karen and I got a bunch of questions from her Facebook audience, and we discussed that next week. So a bit of a Q&A. It's sort of one of those fun ones. I love doing things like that. So look out for that next week. And until then, you can catch me on Instagram at Mikki Williden, or over on Facebook at Mikki Williden Nutrition, or my website, mikkiwilliden.com, which is where you get access to all of what I described at the start of the podcast. And also, if you even just signed up, you would be able to get my weekly emails, which are always good, and also book a one-on-one consultation there. All right, team, hope you have a great week. Talk to you next week. See you later.